Jim Siegler here for Brainwaves. Previously on our show, we covered a few topics on autoantibodies in neurologic disease, with episodes on autoimmune limbic encephalitis with Dr. Ramani Balu, episode 23, and autoantibodies in acquired myasthenia, episode number 18. In today's episode of our brief high-yield Quanta series, we'll be moving even further outside the central nervous system and into the muscle tissue itself to discuss some of the major antibodies seen in inflammatory disorders. Joining me in the discussion today will be Dr. Megha Dhamne.
Hello everybody, so I'm Megha Dhamne. I'm a neuromuscular fellow at the Cleveland Clinic. Thanks for inviting me.
Glad to have you with us. In about a week and a half, you and I are going to air an episode where we talk about the case of a patient with progressive myalgias and proximal weakness, and the patient's ultimately going to be found to have an autoimmune myositis. So to kind of give that episode more background and to prepare the listener for it, let's review what should be known about the clinical phenotypes and some of the antibodies that we see associated with the various inflammatory myopathies. But first, a quick word from the sponsors of this podcast. Don't go anywhere. This episode was brought to you by Audible, the world's largest selection of high-quality audiobooks. To get your free 30-day trial, sign up on audibletrial.com/brainwaves. This week, I recommend Theft by Finding, Diaries, written and narrated by David Sedaris. You can hear this book or 180,000 others at audibletrial.com/brainwaves. We are also supported by Blue Apron, where you can have farm-fresh meals delivered straight to your door in a weekly refrigerated box. Because food is better when you start from scratch. Get $30 off your first delivery by signing up through our blog at brainwaves.me. In general, we find antibodies in the inflammatory myopathies about 60% of the time, depending on what source you're reading. But before we even go into looking for these antibodies, you should at least have a suspicion that there's an acquired inflammatory muscle disease. These patients, typically they're middle-aged or elderly adults, although it can be seen in children, they'll complain for weeks or months of weakness and muscle aches, and maybe even some systemic findings, fevers, rashes, shortness of breath. And we'll talk about these features in more detail in a minute. Interestingly, the ocular muscles are spared in many of these conditions, and this may help you to distinguish an inflammatory myopathy from a neuromuscular junction disorder or a congenital myopathy. The patient should not have any sensory disturbances, like numbness or paresthesias, and on exam, the reflexes should be normal, not absent or reduced as you might see in GBS or CIDP if the symptoms are progressive. And the reflexes shouldn't be brisk, as you might expect with a central or structural process. So when you're suspecting myositis, I've always started by confirming the presence of the itis, by checking for elevated muscle enzymes, CK and aldolase. And a patient's liver function tests may already have been elevated, because these proteins also exist in muscle tissue. But sometimes these tests could be normal, even when there is an inflammatory myopathy.
Right, and that's not unusual. So 70 to 80% of patients with dermatomyositis, roughly they should have an elevation in CK, even up to 50-fold high. But 20% of dermatomyositis patients, a small number, can have normal CK levels.
In these cases, the diagnosis is going to be made by confirming with antibody testing, or, in some scenarios, a muscle biopsy if it's a true inflammatory myositis and antibodies are negative.
So when we send the myositis panel, it tests for the inflammatory myopathies, which would be dermatomyositis, polymyositis, anti-synthetase syndrome, which is a combination of myositis, severe interstitial lung disease, arthritis, and Raynaud's phenomenon. So that's one group. The other group would be necrotizing myositis and overlap myositis.
So a handful of myopathies here, not to mention many others we just don't have time for. The first is dermatomyositis, as Dr. Dhamne mentioned. This can occur in children or adults, and it's characterized by proximal weakness with predominant cutaneous features, the classic periorbital heliotrope rash, an erythematous rash over the neck and shoulders in a shawl sign, a rash over the chest and neck in a V sign, and the characteristic violaceous eruptions over the knuckles called Gottron's sign. And you probably knew about these, But there are other interesting skin findings that are seen in cases of dermatomyositis that are caused by particular antibodies.
So you can see calcinosis cutis or subcutaneous calcifications in patients with dermatomyositis with the anti-NXP2 antibody,
which stands for
anti-nuclear matrix protein 2 antibody. So this is NXP2.
And this antibody is highly associated with an underlying malignancy, either adenocarcinoma of the lung, colorectal cancer, breast, or ovarian tumors. The NXP2 and a second antibody, the TIF1,
the anti-transcriptional intermediary factor, or the TIF1 gamma.
These antibodies are the ones that we see that are highly associated with cancer in dermatomyositis.
Cancer can be diagnosed either simultaneously with the onset of myositis or before or even years after the diagnosis of inflammatory myopathy. So the risk of cancer is greater in patients with dermatomyositis than those with polymyositis. And there's another antibody which is anti-MDA5 antibody disease, which is associated with severe skin ulcers, necrotizing skin lesions. But they may present with just severe skin lesions without muscle weakness. And that's typically described as clinically amyopathic dermatomyositis. So the skin lesions are very important here.
And probably even more important because patients with anti-MDA5 dermatomyositis are at risk of significant pulmonary compromise.
The anti-MD5 antibody disease can be associated with severe interstitial lung disease and carries a very high mortality.
In contrast, some antibodies seem less associated with cancer or interstitial lung disease, like the anti-MI2 antibodies in dermatomyositis. In addition to having a milder phenotype in anti-MI2, these patients are also more likely to respond to immunomodulatory therapies.
Anti-SAE antibody is similar to anti-MI2, which presents with just skin lesions, so dermatomyositis with myopathy basically, and with or without mild interstitial lung disease. Hence, it's very important to identify these antibodies because they define a clinical syndrome. Like each one of them could be associated with myositis, with or without the skin lesions, with or without underlying interstitial lung disease or cancer.
The second of the inflammatory myopathies Dr. Dhamne mentioned would be polymyositis, which is a rare entity by itself. Unlike the other conditions mentioned here, there are no skin changes. It's a purely proximal inflammatory myopathy. More often, when you see this type of patient, they'll have experienced a toxic myopathy in the setting of a medication exposure, something like chronic steroid use, alcohol use, colchicine, statins, or zidovudine in HIV patients. Or the patient has inclusion body myositis, or a necrotizing myositis. The bottom line is, polymyositis remains a diagnosis of exclusion, but that doesn't mean that you won't encounter it in your practice. And when you're sending off antibodies, the Jo1 antibody may come back in this condition. You'll also see positive anti-Jo1 antibodies in many cases of the anti-Synthetase syndrome, which is the third condition Dr. Dhamne brought up. And this disorder is something you don't want to miss because of the high morbidity and mortality associated with interstitial lung disease and occult cancers. The anti-Synthetase syndrome is characterized pathologically by antibodies directed against one of several amino-acyl tRNA synthetase enzymes.
And because of the interstitial lung disease, this has a very high mortality.
Easily the most common antibody in the anti-Synthetase syndrome would be the anti-Jo1 antibody.
And that is seen in about 60 to 70% of patients with anti-Synthetase syndrome.
But other antibodies can be seen a small part of the time too. Antibodies like anti-EJ, anti-OJ,
anti-PL7, PL12,
anti-ZO, and a few others. But none of these carry many other distinguishing features worth mentioning here. And I don't even think I'll remember them at the end of the episode.
Now, the other antibodies which are tested as a part of myositis panel is anti-Srp antibody, which is a cause for which can cause necrotizing myositis.
Srp, or signal recognition particle antibodies, are seen in about 5 to 10% of patients with inflammatory myopathy. Unlike dermatomyositis or polymyositis, which can evolve over weeks and months, symptoms of a necrotizing myositis peak rapidly over days or a few weeks, causing massive elevations in muscle enzyme levels. And this condition can follow a viral illness, it can be seen in cancer, or can co-occur with connective tissue diseases, so all these should be screened in somebody who has a necrotizing myositis. In recent years, we've seen it occur after a statin exposure, in which the weakness will continue despite discontinuation of the statin. In these cases, antibodies to HMG-CoA reductase and not to Srp will be seen in the blood. The last condition Dr. Dhamne recognized was overlap myositis, which encompasses a spectrum of disease that merges with other systemic disorders, like scleroderma. And the antibodies that we see in this category of muscle disease are the anti-U1 RNP antibody, which is the same antibody seen in mixed connective tissue disease, U3 RNP, anti-PMSCL, and anti-KU.
Now, the other antibodies, anti-KU, EJ, and OJ, which are tested as a part of the myositis panel, are seen in patients with overlap myositis. So overlap meaning they are seen with associated connective tissue disorders like Sjogren's syndrome, SLE, scleroderma.
Finally, before we wrap up, novel antibodies against the cytosolic 5' nucleotidase 1A, it's a mouthful, NT5C1A. These antibodies are seen in about 3/4 of patients with inclusion body myositis. So you can send that serologic test when seeing a patient with progressive weakness of the proximal leg muscles and weakness in the finger flexors and atrophy of the forearms. Recent data indicates antibodies against this protein correlate with a more severe phenotype. Patients with IBM who have this antibody have more difficulty with ambulation, they have more dysphagia, and more facial weakness when compared to seronegative inclusion body myositis patients. Unfortunately, we don't have time to talk about many of the other newer antibodies, a lot of which are still in kind of preclinical stages, but hopefully we'll be incorporating them into clinical practice in the coming years. Thanks again to Dr. Megha Dhamne for contributing to this discussion on antibodies in inflammatory muscle disease. Her full episode will air 2 Thursdays from now, so stay tuned for that. If you're really into antibodies, we've covered autoimmune serologic testing in several prior episodes that we mentioned before, one on myasthenia gravis, and another episode on autoimmune causes of limbic encephalitis. So take a look through our iTunes archive to hear those episodes, or check out the blog at brainwaves.me to read about it. Brainwaves is supported by Blue Apron, delivering you farm-fresh ingredients and easy-to-use instructions so you can prepare your own meals at home. Get $30 off your first order by using the link on our website at brainwaves.me. We're also supported by Audible, the world's largest library of audiobooks. Go to audibletrial.com/brainwaves for your free month and first free book. If you haven't taken a moment to rate this podcast on iTunes or wherever else you get your podcast, please take the time to put in a couple stars. We really appreciate it. This episode of the Brainwaves podcast was produced by me, Jim Siegler, music by Cold Noise and Josh Woodward. I'm Jim Siegler. Thanks for tuning in.